When a child comes with a recurrent infection, often you will think in terms of an underlying primary immunodeficiency. In your busy practice, is it possible to diagnose primary immunodeficiency? The answer is yes. Just you need to spend a 5-minute survey to understand the basic pathophysiology behind this primary immunodeficiency. I am Dr. Sharad Balaji. Today we are going to discuss about the step 1 in PID cases and how to investigate them. For each and every country, the territory matters to prevent the invasion of foreigners into your territory. In olden days, we have four kinds of defense mechanism such as Radha, Gaja, Torada, Padadigal. In the same way, in modern days, we have army, navy, and air force. In a similar way, your body has also its own three-tier defense mechanism. What is this three-tier defense mechanism? Defense 1 or tier 1. What is this? Your natural barriers such as intact skin, intact mucosa, and stomach acid. When a microorganism able to invade or able to surpass this tier 1, then comes the tier 2. What is this tier 2? It is nothing but your innate immunity with the help of his army men such as macrophages, natural killer cells, and then neutrophils. Again, if your microorganism is able to pass through this tier 2, then comes tier 3. What is this? They are nothing but your adaptive immunity, and it is divided into two cell lines. The B cell lines, which is mainly meant for extracellular pathogens, and your T cell lines, and it is meant for intracellular pathogens. This is how our defense mechanism works. Right, whenever there is any problem with respect to any of these defense mechanism, you will tend to get recurrent infections. When you get recurrent infections, how you are going to find out the etiology? Let's see. What are all the roles of immune cells? If you think that the role of immune cell is to only fight against microbes, it is not so. So, what does it mean? The role of immune cells is not only to fight against a recurrent infection, but also to fight against autoreactive cells as well as your malignant cells, that is, your cancer surveillance. So, what does it mean? Previously, whenever there is a defect in immune cells, we used to call it as primary immunodeficiency. But now, the term has been replaced by inborn errors of immunity because the manifestations are not only recurrent infections but also it includes a combination of an autoimmunity and an increased incidence of malignancy. So instead of calling it as primary immunodeficiency, let's call it as inborn errors of immunity. Before proceeding to the investigation further, you need to know the pattern recognition. What do you mean by pattern recognition? In the previous slide, we had discussed about T cells, B cells, NK cells, neutrophils, etc. Based on that, we are going to divide it into four things. That is disorders of phagocyte, disorders of B cells, disorders of T cells, and disorders of complement. But before that, you need to know whether this child really needs an investigation towards primary immunodeficiency. For that, you need to have a screening questionnaire. What is that screening questionnaire called as? It is nothing but Jeffrey model criteria, and in that criteria 10 warning signs had been described, and when you have two or more warning signs, kindly proceed your investigations towards primary immunodeficiency. What are all those 10 warning signs? 1. It starts with 4 or more ear infections per year. Second, 2 or more serious sinus infections requiring an admission within a year. 2 or more months of antibiotic within 1 year, 2 or more pneumonias within 1 year, and recurrent deep seated abscess. Any abscess involving liver, spleen, brain warrants an investigations towards inborn errors of immunity. Remember, even a simple failure to thrive can be a manifestation of an inborn errors of immunity, a persistent oral candidiasis. And one important point that I want to stress here is look at the eighth point. What is that eighth point? Need for intravenous infections, intravenous antibiotics to clear infection. That means each and every child who warrants an IV antibiotic to clear the infections needs an investigation towards inborn errors of immunity. It may be surprising to you, but it is the real truth. Because you and me are exposing ourselves to so many virus, bacteria, fungus in our hospitals on day-to-day basis. But why you and me are not developing this kind of infection? It is not because you are antibiotic. It is not because of your wearing mask, hand wash, etc. It is simply because your innate immunity, your adaptive immunity, and your natural barriers are intact, as a result of which only I am speaking and standing in front of you despite being working in a TB institute for more than 14 years. Had a family history of primary immunodeficiency, and the two are deep-seated abscess or septicemia. So, when you have two or more points in this 10 warning signs, you need to proceed for PID workup. But before proceeding to PID workup, you can ask me, what is the first investigation I need to do? Whether I need to do a workup for a primary immunodeficiency. Beware of mimickers. It doesn't mean that recurrent infection can occur only as a result of defect in your innate or adaptive immunity. It can also be due to acquired immunodeficiency such as HIV. When you get recurrent infections, pneumonias along with oily stools, it can be cystic fibrosis. A recurrent atoria along with the bronchiectasis can be due to primary ciliary dyskinesia. It can be due to a congenital heart disease with the left to right shunt, such as AST, VST, and PDA, or it can be due to lung malformations which predisposes a child for recurrent pneumonia involving the same site, or it can be due to aspiration. So, what does it mean? Before proceeding towards any investigation of primary immunodeficiency, kindly think about all these in your mind, and if these things are negative or less likely, then proceed your investigation towards primary immunodeficiency. Yes, I have a case with a recurrent infection. Now, all these investigations for these diseases turned out to be negative. Then, what should I do? I need to do investigations for PAD. But before that, you need to know the pattern recognition. What do you mean by that pattern recognition? Based on the discussion of three-tier mechanism or defense, let me divide our primary immunodeficiency into only 5 types. What are all they? They are nothing but disorders of phagocytes, disorders of B cells, disorders of T cells, disorders of complement function. But as far as Immunological Society is concerned, there are 10 categories of primary immunodeficiency and inborn errors of immunity. But to make it clear and to make it easier, I have divided into only 5 divisions. So, phagocyte, T cell, B cell, complement. Along with that, for convenience sake, I have added one more thing. What is that? Chronic eczema with recurrent infection based on the frequency number of cases that we are seeing in our cohort. Right. So the following one single slide is going to help you to screen primary immunodeficiency within 5 minutes. So get ready for the next slide. Right. So phagocyte. When do you suspect phagocyte? Phagocyte means disorders of neutrophils. How do you know that particular child has got disorders of neutrophils? It is very, very easy. When neutrophils are not working, it means you will get recurrent suppurative infections. It can be recurrent suppurative lymphadenitis. It can be recurrent organ deep-seated abscess. It can be a persistent pneumonia, or it can be a non-healing ulcer resembling your ecthyma gangrenosum. So remember, apart from suppurative infections, a non-healing ulcer can also be a manifestation of a neutrophilic defect. Now, what is the defect with respect to this neutrophil? It can be quantitative or it can be qualitative. Quantitative means what? Reduced number of neutrophils. So when you have a pattern of recurrent suppurative infections, look for quantitative defect involving neutrophils. If it is less than 1500 cells per cubic millimeter, it is often due to quantitative defect. So what are all those diseases called as? It can be congenital cyclical neutropenia. Second question is increased absolute neutrophil count of more than 25,000 cells per cubic millimeter. So what does it mean? The answer is simple. The first one is quantitative, the second one is qualitative. Whenever we see a case of infection with the increased neutrophil count, we often think in terms of a leukemoid reaction and your bone marrow responds to that infection. But it is not so. In this modern era, whenever you find an increased neutrophil count, it can be a manifestation of an underlying neutrophilic qualitative disorder. It can be due to leukocyte addition defect, or it can be due to chronic granulomatous disease. And with the help of your pathologist friend, you can try to find out the presence of giant granules in neutrophils, so that it can be a manifestation of Chidiac-Higashi syndrome. So recurrent abscess means, recurrent suppurative infection means, or non-healing ulcer means, look at the neutrophil count. The low count or high count both indicates an underlying phagocytic disorders. Then comes your B-cell disorder. Your B-cell is mainly meant for immunoglobulin production, that is antibodies, GAME. These antibodies are mainly meant for invasion against polysaccharide microbes with the polysaccharide capsules, that is Haemophilus influenza and pneumococcal. When B cells doesn't work, your antibodies are not produced, so you will get recurrent pneumococcal infections or recurrent Haemophilus influenza infections. And these infections usually produces recurrent OPS. O means recurrent otitis media, P means recurrent pneumonia, S means recurrent sinusitis. The first 6 months of life, you have passively transferred antibodies, as a result of which you are less likely to get pneumonia due to B cell deficiency in first 6 months of life. But after 6 months of life, your body needs your own B cell. When it is not present or not producing the sufficient number of immunoglobulin, you will tend to get recurrent pneumonia, consolidation, otitis media, and sinusitis. What is the clue for that? Simple. Each and every one of us, particularly in the pediatric age group, between 3 years and 9 years, you need to have a good tonsil. You need to have a good adenoid. Whenever B cells are not present, you will have absent tonsil. Why? Tonsil has germinal center. This germinal center has got B cells. So when there are no B cells, no germinal center, so no tonsil. Any boy who comes with a single consolidation, look at the tonsil. Absent tonsil or small tonsil, it's a right time to investigate a child for B cell deficiency, and you can right royally order immunoglobulin profile. But before ordering an immunoglobulin profile, look at the tonsil. And one more simple clinical clue is in LFT you can see serum globulin. A serum globulin of less than 1.8 grams per deciliter is often in favor of an underlying immunoglobulin deficiency. Wherever immunoglobulin profile is not available, you can order an LFT, you can look for serum globulin, and if it is less than 1.8 grams per deciliter, it is an indirect evidence towards underlying B-cell deficiency. And there are so many types right now, but for an introducer, you need to know if it is quantitative defect. Quantitative defect means no B cells, no immunoglobulin. That is Bruton's A gamma globulinemia. Or qualitative defect. Qualitative defect is CVID, that is common variable immunodeficiency. That means B cells are present, but it is not producing the respective immunoglobulin. So, what is the simple clue that you can look for? Yeah, any person with consolidation, kindly look for the presence or absence of tonsil. Kindly look for the amount of serum globulins in LFT. Right. Then what about T cell disorder? T cell disorders are the one which is the master orchestra. Okay. He is the one who controls each and every cell in the body. So when T cells are present, it immediately manifests after birth, invariably between 2 to 6 months of life. Any child with persistent pneumonia or persistent diarrhea between 2 to 6 months of life, instead of looking into the lobar involvement, whether it is upper lobe, middle lobe, or lower lobe, kindly look into the presence or absence of thymus. So, in any child with persistent pneumonia and absent thymus, invariably it is a case of underlying T cell disorder, particularly severe combined immunodeficiency. So, this is the X-ray clue. What is the blood clue? Very, very simple. An absolute lymphocyte count of less than 3000 cells per cubic millimeter is an indirect evidence towards severe combined immunodeficiency. And what are all the disorders involving your T cell disorders? It can be a Diger syndrome or it can be a severe combined immunodeficiency. The third pattern recognition is eczema. Any child with a recurrent pneumonia or some other infection, when they present with eczema which is not responding to your steroid creams or oral steroid, think in terms of two disorders. One is Viscott-Aldrich syndrome, another is hyper IgE syndrome. A boy with resistant eczema, blood in stools, and infection, unless otherwise proved, it must be a case of Viscott-Aldrich syndrome, and platelet invariably will be less than 50,000 cells per cubic millimeter. And they are small platelets, that's why a mean platelet volume of less than 7 femtoliters is suggestive of Viscott-Aldrich syndrome. The second thing is any boy or girl with chronic eczema and persistent infections, look at the eosinophil count. An eosinophil count of more than 700 cells per cubic millimeter can be due to an underlying hyper IgE syndrome. And finally, what is the role of complement? There are three roles for complement. The first complement role is C1q. What is the role of C1q? The early complement C2C4 reduces or destroys the autoreactive antibodies. So C2C4 is reduced or not produced means your autoreactive antibodies will be plenty, leading on to SLE like illness. That's why when you have an SLE like illness less than 4 years of age, instead of thinking about an autoimmune disorder, think it must be a manifestation of underlying early complement factor deficiency. So the manifestation of C2C4 deficiency is SLE like illness less than 4 years of age. Second, what is the role of C3b? It is an opsonin and it helps your spleen destroy your microorganisms. So what will happen? That is your capsulated microorganism. So the same pneumococcal hemophilus can produce septicemia or infection when C3b is not present. You must be asking now. The same recurrent pneumonia otitis media can also occur in immunoglobulin deficiency, can also occur in C3b deficiency. So how can I differentiate? Remember, your immunoglobulin deficiency is more common than C3b deficiency. So recurrent OPS with a normal immunoglobulin profile means you need to suspect an underlying C3b deficiency. And finally, C5b to 9, any single episode of meningococcal meningitis also should be investigated for underlying complement factor deficiency. And you must be wondering, for this SLE like illness, for this recurrent pneumonia due to C3b, meningococcal meningitis, what should I do? Complement CH50 assay, or do I need to any genetic workup? The answer is very simple. No need to forget about these things. You need to do just C3, C4 level that you people are doing in your day-to-day practice if any case of suspected post-streptococcal glomerulonephritis comes. So instead of thinking about all hi-fi investigation, just do C3, C4 levels. If the levels are normal, it is unlikely be due to complement deficiency. Right. So what is the 10 commandments with respect to this inborn errors of immunity in office practice? An absolute neutrophil count of less than 1500, 1. An absolute neutrophil count of more than 25,000, 2. Giant granules in neutrophils, 3. Absent tonsil, absent thymus. Serum globulin less than 1.8 grams per deciliter. An absolute lymphocyte count of less than 3000 cells per cubic millimeter. Microthrombocytopenia, platelet less than 50,000 cells per cubic millimeter, along with an MPV of less than 7 femtoliter. Eczema with eosinophil count of more than 700 cells per cubic millimeter, and finally C3, C4 levels. These 10 investigations can be done even when you are in an upgraded PHC. So this is the carry home message from this step 1 video towards inborn errors of immunity screening. Thanks for your patient listening. Bye bye.